show speakers here today. Now, for over 50 years, community health centers have been at the cornerstone of providing affirming, high-quality health care for their patients, including the LGBTQ plus community. Yet significant disparities in access to health care, chronic disease, health outcomes, and social determinants of health still exist. This has been especially true this past year during the pandemic, where critical access to preventive services, medical care, and vaccines were limited. Today, we explore how health centers have driven monumental change in the LGBTQ plus health and continued efforts to assure quality, affordable, and accessible health care for all. I especially want us to focus on how SUDS and behavioral health is so important in the care of our community. Despite the 40 years I've been an out gay man, we have seen great strides, but there is still much misunderstanding and hate in the world. Just today, I read the story of a 12-year-old boy in Georgia who was videotaped by his own mother while other family members slapped and berated him. They had shaved the word gay into his hair. Watching that video broke my heart. I mean, we need to be there for him and others suffering from homophobia and racism. So I'm sure we will address these in our comments today. So thanks again for joining us, and back to you, Sherry.
Thank you, Jim, for those sobering but very necessary remarks. Before I introduce our first speaker, I would like to take this opportunity to remind those of you joining us that tomorrow, June 30th, is NACHC's National Day of Action. This is a day aimed at supporting community health center infrastructure funding. As Congress moves forward in infrastructure package, we must ensure community health center needs are heard. You can find a list of resources to support our advocacy efforts on this slide. Thank you in advance for standing up for health centers. Now let me begin our program by introducing Anthony Fortenberry, Chief Nursing Officer at Callen-Lorde Community Health Center. Please join me in welcoming Anthony, who will give an overview of the services NACHC provides to support health centers serving the LGBTQ plus community. Anthony, the floor is yours.
Thank you so much, Barry. NACHC and health centers have been at the center of this crusade to continue providing culturally responsible care across the life cycle. Now, while NACHC and health centers have always provided care to LGBT populations, in 2006, NACHC convened an LGBT health special interest group to specifically serve as a focal point within NACHC for monitoring LGBT health issues and to help facilitate service improvements. In 2007, NACHC distributed an information bulletin on caring for LGBT patients in health centers. And in 2013, NACHC formalized its commitment by establishing the LGBTQ Health Taskforce. The LGBTQ Health Taskforce focuses on training health center leaders, ensuring LGBTQ cultural and clinical competency, and improving health outcomes for LGBTQ populations. Today, there are currently 31 members representing consumer boards, health centers, and primary care associations who meet throughout the year, both virtually and in person, including during this year's Community Health Institute and Expo. I am privileged to serve as the chair of the LGBTQ Health Task Force. The task force takes a leadership role in identifying emerging issues related to the clinical care of LGBTQ people and guides effective responses to these issues through both policy efforts and as a resource for best practices. The task force provides this resource for NACHC committees, task forces, and the board of directors. We also work to develop an infrastructure that promotes the task force as a resource to others, respond to requests for input from NACHC committees, task forces, and the board of directors, and then also proactively bring issues and concerns to these committees, task forces, and the board to advocate for LGBTQ patients. We provide expertise to NACHC staff during the development and implementation of programming, training, and materials. This includes those that are both LGBTQ specific and also non-LGBTQ specific to ensure we are advocating best practices for all of our patients. To this end, we utilize collaboration with both LGBTQ experienced and non-experienced health centers as a source of expertise and knowledge in the provision of care. We respond to requests for input from NACHC staff and proactively bring opportunities to NACHC staff to help develop new or improved programming, training, and materials. In addition to the task force, NACHC captures promising practices from the field and shares them during sessions at NACHC conferences, blog posts, and webinars, including Ask Me Anything webinars with health center leaders. This month, for Pride Month, NACHC held 2 webinars, How to Build and Finance PrEP Delivery Models, and the second, Telehealth and PrEP HIV Care Outcomes. Through CDC funding, NACHC and partners supported 10 health centers in 9 states, working on improving health outcomes for their LGBT patients. Health center quality improvement teams participated in a practice improvement collaborative, and each health center had a provider champion attend a bi-weekly Project ECHO meeting focused on LGBT health. Much of the work included training staff to provide clinically appropriate, culturally responsible care, creating a physical environment that is welcoming to all patients, including LGBTQ patients, collecting patient sexual orientation and gender identity data, and engaging patients in conversations about their sexual health. NACHC has created materials for health centers, including the Transforming Primary Care for LGBT People Toolkit, which compiles promising practices around identifying LGBT patients and engaging them in culturally responsible, clinically competent care. Priority interventions are supported with implementation tips, tools, and resources, and we'll be sure to put the link in the chat for that wonderful toolkit. Thank you all for participating in today's webinar. Happy Pride. Sherry, I'll hand it back to you.
Thank you, Anthony. Happy Pride back to you. I am thrilled today to introduce our esteemed group of leaders and colleagues. First, we are very excited and honored to have Dr. Rachel Levine, Assistant Secretary for Health at the U.S. Department of Health and Human Services, who has graciously provided us with a special message regarding today's topic.
Thank you for having me here to celebrate the role community health centers have played in advancing LGBTQ+ health and discuss the path forward. As the first openly trans person in a Senate-confirmed position, I am especially honored to be here, speaking with all of you and to serve as the Assistant Secretary for Health. I certainly recognize the importance of service and the importance this role has in leading America to healthier lives. Throughout my life, I have felt a call to serve and to help people. During my career in academic medicine, I served my patients and their families, students and staff, hopefully with purpose and dedication to make life better. That is something I have in common with all of you. We help people. We help young people, their families, our communities, and our nation. Much of this work is done through HRSA's Health Center program. Our community health centers help disadvantaged communities, including the LGBTQ+ community, who often face ongoing and complex medical issues, from higher rates of mental health issues to HIV/AIDS and more. HRSA's health centers serve 1 in 11 people in the United States, which makes them a tremendous resource to ensuring that all people have safe, affordable access to care and set a high standard of care for others to follow. Health centers provide patient-centered care that ensures LGBTQ+ people can access needed preventative and primary health care services. We've also included the LGBTQ+ population in health center grant applications as a key population served. Just this past March, HRSA announced nearly $99 million in funding through HRSA's Ryan White HIV/AIDS program to expand access to HIV care, treatment, medication, and essential support services. The Biden-Harris administration remains committed to funding these invaluable programs that have been a lifeline for the LGBTQ community. Since 2000, HRSA has routinely collected and published data on transgender people in its Ryan White program reports. It is updated annually and available at the state level on HRSA.gov. HRSA is playing a key role in ending the HIV epidemic in the United States, and HRSA-funded health centers are supporting the Ending the HIV Epidemic initiative by serving as a key point of entry for detection and diagnosis of people living with HIV, as well as the provision of PrEP. HRSA is also working with its training and technical assistance partners to capture the promising practices and successful strategies implemented by health centers to improve HIV prevention services and care delivery across the entire health center network. Our National LGBTQ+ Health Education Center, run by the Fenway Institute, helps community health centers improve access to care for LGBTQ+ populations. We've made strides in training and education for doctors and nurses. Our health centers help inform the guidelines for clinical care for the LGBTQ+ community. We provide treatments for mental health, substance abuse, and other whole-body approaches to treatment for issues that disproportionately affect the LGBTQ+ community. This includes a Stop Bullying campaign with a specific section directed to LGBTQ+ youth. We've still got a long way to go, which we see plainly in the disparities that COVID-19 has brought to light. I am proud to have an ex officio seat on the COVID-19 Health Equity Task Force, which will provide recommendations to the President on how to mitigate the health inequities caused by or exacerbated by the COVID-19 pandemic, and how to prevent such inequities in the future. We're also working to make healthcare coverage more affordable, which is especially important during COVID-19. There is a 2021 special enrollment period on healthcare.gov through August 15th. These are just the first steps in our long journey ahead. I look forward to working with all of you to help usher in the next era of health equity and ensure that health equity truly means health equity for all, building on the lessons learned during COVID-19 to build a brighter, more inclusive future. Thank you.
We appreciate those important highlights, Dr. Levine, and are grateful for all you do for our country's well-being. It is my pleasure to now introduce the rest of our featured panelists and then turn things back over to Jim. So Channyn Parker is Director of Strategic Partnerships at Howard Brown Health in Chicago, Illinois, the largest LGBTQ+ health provider in the Midwest. Reginald Vicks is a registered nurse and COO of CrescentCare in New Orleans, Louisiana. Jim, take it away.
Oh, there I am. Sorry. Oh, thanks, Sherry. So let's jump into our first question. As has been discussed, health centers were some of the first healthcare providers for the LGBTQ+ community. In what ways have health centers built their capacity and prepared themselves to care for this population? Channyn, let's start with you and then Reginald.
All right. So again, thank you so much, everybody, for joining me this afternoon. I hope that my volume is okay and everybody is hearing me well. Okay, cool. All right. So again, I'm Channyn Parker. I work with Howard Brown Health here in Chicago, Illinois. So to answer your question, which is a great question, at the nascence of health centers that really focused on the needs of the LGBTQ community, that focus has been largely siloed, right? Particularly to the care of our bodies and getting a bit more detailed in what that care looks like. It was particularly focused around STI, STD prevention and transmission. So Howard Brown Health was born out of that need back in 1974 when a group of students from the Chicago Gay Medical Students Association, I believe I got that right, grew concerned about the rising rates of sexually transmitted diseases among gay men. Similar to the organizations that folks serve on in this panel, during the 1980s and on up until recently, our focus was largely around HIV/AIDS treatment and prevention. So here we are, right, in 2021, and you heard me earlier use the word siloed. And the reason why I use that word is because, again, healthcare organizations, not exclusive to our own, have treated individuals through a rather myopic lens, I would say. This kind of takes me back to a similar discussion where a question was asked somewhat to this, right? And one of the things that I have said, and I believe that this was done through best intentions, but in many ways, we've reduced our community to a set of public health acronyms. And what I mean by that is, we have called folks MSM and PLWHIV, TWOC. But when we really think about it, where is the consideration for the whole person? Especially when it comes to a holistic approach to care. So to go back to your question, right, in what ways have health centers built capacity and prepared for, the vulnerable population that we're working with? Well, one, we've built capacity through the summation of our experiences and being dedicated to the improvement of our care delivery through to all the community members who walk through our doors, right? We have built that capacity by recognizing that, yes, we can treat diseases with meds, but people need a lot more than medicine. People need preventative care. People need food, housing supports, access, and getting over those day-to-day barriers which express themselves in a variety of systemic ways, which do bar people from their access to thrive. That also includes mental health supports as well as substance use as well. I would also add that unlike in the years past, we've built capacity through listening. Again, I want to highlight that word, listening to patients and allowing them to be in the driver's seat of their care as opposed to the other way around. We've also increased capacity through the provision of competent education and research, such as being done through our department, Education, Research, and Advocacy Team, which is also known as ERA in short, right? To kind of conclude, as far as this question is concerned, one of the things that we have learned from our activism during the AIDS crisis of the 80s and 90s is that we have such political power and the ability to hold our political leaders' feet to the fire. Going back to our ERA team, which focuses on policy, championing for things like the insurance of the stability of ACA, that is so important, right? Because again, just like with Howard Brown and other FQHCs, that supports us in being able to provide that comprehensive healthcare that serves all the individuals that walk through our doors. Also too, when necessary, supporting our patients in healthcare enrollment, regardless of their ability to pay. Those are things that are super important. So I can go on forever. I kind of want to digress so other folks can jump in. So again, thank you so much for that question.
Thank you. Reginald.
Hi, Jim, and thank you, Channyn, for a very comprehensive and contextual look at where we've come from the early days. And I just want to build on some of what Channyn expressed. Healthcare centers are really at a great intersection when it comes to service in the community. We serve the most vulnerable in our community. And there's a rich historical context just related to the movement and the work of community health centers. many of the things that we've done over the past years, starting with back in 1983 at CrescentCare, a group of people got together and formed an advocacy, I guess, sort of committee or group, the NACHC Taskforce. And it was built out of a social service outreach perspective to address issues related to the HIV epidemic at the time. And this was around 1983, so it was right at some of the peak of the pandemic in different parts of the country. And the opportunity that NACHC Task Force brought to the community to receive information, receive support and compassion in the midst of a pandemic has grown into our work as a primary medical center, an FQHC, and a provider of wraparound services for our community. And I want to highlight that for a minute. NACHC has put together a toolkit for how to build capacity for service to the LGBTQ community. In the three basic areas, we want to identify our clients, we want to engage our clients in care, we want to manage preventive care, and at the end of the day, certainly we want good, high-quality outcomes related to improvement of health for our clients and the community members that we serve. So one of our focuses, and I think many community health centers around the country have taken up this mantle, is a focus on creating an affirming environment where people feel welcome and they feel like they have a medical home. So we've looked at educating our providers, we've looked at educating our support staff, highlighting a focus on a trauma-informed approach, looking at the issues that really affect the community. Dr. Levine spoke about substance use disorders and mental health issues. We deal with issues of intimate partner violence and some of the things that Channyn has spoken about as well. But we also, in addition to that, consider some of the things that impact our LGBTQ community more so than other members of our community and the population. So, for example, we have to identify those clients. We have to have intention around, welcoming individuals into a healthcare environment where they've really not received quality care services in the past, or even had access to those services. Venue-based outreach initiatives where we actually go out in the community and inform individuals in our community about what is available to them. And community health centers offer a unique opportunity to do that. Because, again, Channyn mentioned this earlier, because we serve individuals who typically have not had health insurance, we help them understand how to advocate for themselves, we help them get insurance. Louisiana is a Medicaid expansion state, and so we have been able to certainly provide a gateway for clients to be able to obtain those benefits and then access services without cost to themselves. Another area that I think we should highlight is the huge disparity in racial equity when it comes to individuals obtaining high quality services, as well as having access to high quality clinicians. Again, community health centers provide that. but we have to give our providers and our staff the tools that they need. One last area I want to speak to is relative to workforce development. It's very important that we reflect the community that we serve. And so healthcare centers have been very intentional about the workforce development aspect of this and creating pathways for employment and service for the people that we actually serve in the community. So we have looked at our hiring practices, making sure that we highlight that we do not discriminate against members from different groups in our community, and that our staff actually reflects the community that we serve. So I'll stop there. I could also go on and on.
Hey, no,
but I'll stop there, Jim.
Thanks. No, Dr. Reginald, Dr. Levine mentioned that there are several health-related issues facing our community in addition to HIV and AIDS. How do you prioritize these issues, and how do you balance them with making sure you have racial justice, health equity, and meeting the needs of the LGBTQ community?
Yeah, thank you for that question, Jim. So some of the work that we've done around health and racial equity includes creating a space for advisory groups to come in and offer us feedback on how we can be better at service. We've looked at, we've actually been very intentional at CrescentCare, and I believe this is a movement that's expanding throughout the country, especially in community health centers, where we're looking at systemic issues and systemic opportunities to change systemic processes within our organizations to be more inclusive and to create an environment that's more welcoming, but also culturally sensitive and competent. One of the issues that, one of the things that Dr. Levine brought up was substance use disorders. And so incorporating interventions for substance use disorders within our clinics is a critical piece, since we know the data shows that this is something that a social determinant and a public health an issue that impacts LGBTQ communities in particular. We could talk about, again, there's a lot of information here to unpack. We could talk about certainly the things that impact our transgender community, in particular, our transgender and non-binary, and those transgender and non-binary communities of color, even more so impacted by different trends relative to sexually transmitted disease, substance use, and mental health disorders.
Great. Channyn, turning to you, what invisible groups do you see within the LGBTQ community that may need greater health center support, and how would you address this?
I love that question for a few reasons. I'll start here. I always kind of wince when we use the word invisible to address certain members of our community. And here's why. Because when we use the word invisible, that word actually shirks responsibility. Here's the fact, right? The fact is that trans people, getting more granular, right? Trans women of color, youth who are experiencing homelessness, they are not an invisible population. They are a forgotten population. And if I were to take it a step further, they are an ignored population, or even better, a throwaway or an expendable population. So I think a lot of times when we say invisible, it's to somehow speak to an oversight, on our part, when in fact, I don't think it's an oversight at all. I think it's very intentional. Invisible people don't walk through our clinic doors. And if they did, you simply wouldn't be able to see them, right? I mean, you are fully aware that there is another human in your face. You've just chosen to act as if this is some great new conundrum. And again, that this population suddenly appeared out of thin air right before our eyes. Yeah, so you see, I'm pretty passionate about that. So again, prior to recently, we've turned our attention externally, right, as opposed to internally. And we've kind of ignored or maybe been invisible to the collective harm that we've done through the years of just apathy, inertia, and just maybe even good intentions, right? So I'll go back to the question. Let's start with young people. We know that our youth are in crisis. They experience alarming rates of homelessness. And honestly, due to reasons that the viewers and that the panelists already know, right? That is through family rejection, that is through discrimination, through violence, right? Being amongst those factors and a lot of other things. I think that any of us, whether we find ourselves in a certain amount of privilege or lack thereof, understand that if we were put out of our homes and forced to fend for ourselves, we would do anything that we possibly could in order to survive, right? So that experience, whether we've dealt with it personally or not, would not be lost on any of us. For that reason alone, we have our Broadway Youth Center, which does serve young people experiencing homelessness between the ages of 12 and 24, through the provision of an array of services which are designed to stabilize young people going through some pretty tough situations. I like to center the Broadway Youth Center services in dignity restoration. Yes, we provide that GED education stuff. We provide food, meals, things like that. But also we provide the dignity of a hot shower, right? Laundry, being able to get your clothes clean, being able to sleep someplace safe for a couple of hours. Those are those things that young people who are in such critical moments of their development are missing. So again, right, that call to action, actually putting those things into place, speaks to the fact that these are not invisible people. We see them right here in front of us and we choose to act. Going back to TGNC people, or trans or non-binary or non-conforming people, more specifically trans women of color, and even more specifically Black trans women, TWOC is a very broad term, going back again to that acronym statement I made earlier. The experience of crushing rates of violence. Who would have ever thought that murder would become a public health crisis? We think about public health crisis being things such as communicable diseases and things like that. We just came off we're still in the throes of a pandemic. But let's think about this other long withstanding pandemic of murder that trans women have been experiencing for a long time, not because they're invisible, again, right, but because of the lack of prioritization. Another huge factor, discrimination. We know that trans people or non-binary folks face huge amounts of discrimination, are barred access from employment, housing, shelters, healthcare, all of those things, right? So one of the things that we at Howard Brown aim to address are those things, and we aim to address them through providing cultural competent care, trainings to individuals who would be charged with our population's care, but also too through those legal supports that we provide. We support folks in accessing documents to help them change names, gender marker letters, right? And those other things that folks need to ensue in order to have documentation that is congruent to their identity or presentation, if you will. We have transgender services. That is a huge one. A forgotten topic that we always kind of glaze over or just don't kind of think about. Trans people are more likely to access Black market hormones or body augmentation things in order to, again, have their bodies aligned with how they feel. We know that that causes a host of issues that can happen in the immediate, right? Or it can happen longer term down the line. So these are some of those things that we need to think about and look at when we're specializing or calling ourselves specialists in transgender care. We are more than hormones. We are more than HIV, STI prevention, right? Like there's those other things that we need to focus on as well, which our transgender services departments do address. And the last thing I'll say is that due to that discrimination, due to that violence, and I want to pause really quickly because when we think about violence, we oftentimes think about violence as hand to face. We always think about it as something physical, when in fact, violence actually is that emotional lack of safety. Violence is the discrimination that we experience on a daily basis, right? We know that trans folks are more likely to make less than $15,000 a year for the rest of their lives, which in turn has trans people in contact with the justice system, right? So what we also do is we support with court supports as well, in hopes of record expungement and sealing, so that way trans folks or TGNC people can actually move on with their lives and access the ability to thrive, right? Not just survive. So I will kind of stop there.
Yeah, I understand. So back when I was in my 20s, when HIV was not very public or visible, we created things like ACT UP and we did marches, and we didn't give up. We sort of like made noise and continually made noise, something like the Black Lives Matters of today movement is doing. And so I'm hoping that we can do that with this, invisible trans community, so that we can get them out there more open, so people are more aware of their issues. And so I'm a very big support of that. So I guess we want to wrap this up by talking a little bit about health equity work. It's never complete, and we know that currently there is a strong focus on trans people of color and the violence inflicted on them. Now, to wrap up today's fireside chat, what is your hope for the continued progress of community health centers and their impact on LGBTQ care? Reginald and then Channyn, your takes on this?
Yeah, hi, Jim, and thanks for that question. The health equity work is never complete. A truer statement was never spoken. It's an ongoing process. It's an evolutionary process, and it's a really making a commitment to a change and managing that change on an ongoing basis and being very intentional about it. Like I said before, and Channyn has spoken to this as well, community health centers are at a unique intersection to be able to promote health equity. And that has been the mission of community health centers since the movement started. For us, in our work in the LGBTQ community, I will say this, that trans people of color, Black trans people, are experiencing some of the most egregious disparities in the healthcare system and in the community as a whole, as we've ever seen in our community, dealing with any segment of the community. When you talk about invisibility, you talk about not being intentional, or rather being intentional about not seeing. And I think that community health centers are in a unique position to raise that awareness. violence against the most disparaged members of our community is often intentionally not seen. And to Channyn's point, that includes ignoring what's in front of us. That includes not participating in interventions that support people getting into care and getting their basic needs met. And that intention contributes to what has been described as the public health emergency relative to social determinants, as well as, direct impact on healthcare status. And what I would say also is that, and the pandemic has really exemplified this, that domestic violence and intimate partner violence has increased significantly, but it's always been there. And one of the things that community health centers are positioned to assist with is supporting not only the primary care needs of community members, but also the mental health needs of community members. And we have to recognize that that wraparound service model is one that has true impact on the community and is very effective in helping people become more self-determined about their health care as well as their personal well-being.
Since we have limited time, Channyn, I have a question in the chat. So I'm wondering maybe you could answer this. How does criminalization of sex work, drug use, homelessness, and poverty impact your patients? And how is your health center working to address these impacts with your patients?
That's a great question. So it hugely has a huge impact on our patients. Again, as I spoke to some of the more harrowing statistics around TGNC folks, the patients that come through our door with these life experiences are oftentimes living through those very things. So one of the things, again, as you might have heard me say at the top of the discussion, that we allow folks to be the driver in the driver's seat of their healthcare, but that also looks like them having autonomy over their lives, right? So in kind of a spinoff of the harm reduction model, what is it that you need to get through today? And how can we support you in moving into a step or a place that feels best and affirming for you? Because here is the reality. The reality is none of these panelists, including myself, or the individuals who we work with, have to live the lives of those that we serve, right? We are going to go home when it's all said and done. So we can talk, we can say what we want to, we're blue in the face, but until we're actually providing them access to, get out of these things, if that's what they want, then the best thing that we can do is offer support. And that support is done through meeting folks where they're at. I know that sounds a bit cliche, but it is tried and it is true. So I could expound on that for a long time, but I know we're coming towards the end. So I will say that take inventory and assessment of what are the individuals who are sitting in front of you, what are they saying that they need? And take inventory of your organization's ability to provide these things. If your organization cannot, that is how you build partnerships with orgs who can, right? And you help to refer and provide those things for those individuals to gain access to that. I'll kind of stop right there.
That's great. Thank you. Wow, this was really wonderful, both of you. That was great interactive discussions and questions, and I look forward to future ones. So thank you to our incredible panelists, and Sherry, back to you.
Yes, thank you. Thank you to our esteemed panel of LGBTQ plus advocates today. Wow. Well, as you know, NACHC is celebrating its 50th anniversary this year, and these monthly fireside chats offer an opportunity to highlight the impact community health centers are making every day across America, especially in this time when we're still fighting COVID. And speaking of COVID, we are excited to be supporting the White House's goal to vaccinate 70% of all adults living in the United States by July 4th. We are partnering with DoorDash and Direct Relief to provide $2 million in gift cards to community health center communities. Please visit the link on the screen to learn more. NACHC is also honored to represent the voices of 30 million patients, 14,000 nonprofit community health center sites, 253,000 staff, and 12,000 community and consumer board members. You can visit our website and click on the 50th anniversary screen on our scrolling homepage to hear all about the past webinars. So thank you for attending, and please join us next month on July 27th at 2 p.m. Eastern, when our topic will be climate change, environmental justice, and health centers. Thank you for your time.